Hello, beloved friends, and welcome to another installation of Kidney Talks with the Ron and Joy Paul Kidney Center at the George Washington University. And I am Reverend Dr. Kendrick Curry, one of your co hosts for this wonderful opportunity to learn more about kidney health. We always have with us the stalwart, venerable Dr. Clive Callender, who is also with us. He is a professor of surgery at Howard University. We have Dr. Joseph Keith Melanson, who is the chief of the George Washington University Transplant Institute. And today, our special guest is Dr. Antonio Fuente, who is in the departments of professor of in the Department of Psychology and Neurology at the George Washington University. And I'm just so excited about his topic today. He's going to speak on brain aging. Brain aging. What is normal aging and healthy brain behavior? Welcome, gentlemen. And I'm excited about today's topic. Dr. Melanson, Dr. Callender, Dr. Fuente, uh, uh, let's get ready to roll.
Well, sounds good. Looking forward to it. Let's see if I can. There goes the slides. Perfect. I don't know if others wanted to say some words initially, but I'm excited and thanks for the invitation to talk today. By background, I'm a neuropsychologist, and this is a topic that we see every day in clinic in terms of patients coming to see us and wondering, hey, do I have some problems with my memory? Is this just aging, or is this more than aging? And should I be worried about it? And so hopefully we'll cover a good amount of things in terms of the topic in that, and you'll leave today having a better understanding of what is normal aging and what's not so normal, and then also what are some things that you can do about it. I think importantly, regardless of what you're experiencing, people always want to know, what are the things that I can do about it? Sure, you can talk to your doctor and we'll talk about that, but also what are the behaviors or lifestyles changes that I can make or my family can make to improve my brain health. So to start with just an understanding of aging and thinking about cognition, there's this graph here, and it's not all downhill. There are certain things that do change with age. And by here, what you see is fluid intelligence and then crystallized intelligence. And we'll walk through those, but you can see that fluid intelligence is something that does tend to have a downward trend in normal aging. This is completely normal, versus crystallized intelligence actually tends to grow. And so what are these two things? This comes from Raymond Patel, and crystallized intelligence is really what you think of as being wisdom, right? We hopefully get wiser with experience and in age, and certainly the science would back that up. That really does increase over our lifespan. That's the half glass full part. The half glass empty part is, unfortunately, our fluid intelligence normally does decrease over time. And so you might hear some stereotypes that we slow down when we age, and the science would actually also back that up. And so our multitasking abilities, our ability to hold things in our mind and do other things simultaneously also tends to decrease. So in one sense, things do get better, we get wiser. In other sense, things do slow down a little bit for us. Maybe it's just that we get wiser and so we slow down. I'm not sure we could totally prove that point, but those are some normal changes that we have. But if we go into memory, you wonder, okay, well, I'm walking into rooms a lot. I'm forgetting what I'm thinking. That is pretty typical and really common as we age. I might not remember today is February 9th. I might think it's the 8th or maybe even the 10th. near misses like that are quite normal as well. Where did I put my phone, my keys? My long-term colleague's name. I know him. I can see his face. I can't pull up that name. And obviously, depending on the frequency, some of these things, if they become more frequent, it's more concerning. But these are all examples of really quite typical normal memory loss with age. What's more concerning here is when you start to have difficulties really managing your own affairs. Maybe you're getting lost in familiar places. You might be asking the same questions, or really forgetting conversations that you had maybe 20, 30 minutes ago. Losing track of time. All right. And so I gave you the example about the date. If a patient tells us it's February 8th, myself, I'm very guilty of maybe being a day or two off. But we shouldn't be an entire season off. Although DC, it's quite beautiful today, it's still winter. And so if we start to make those larger errors, that becomes more concerning. That really makes it important for us to seek out some medical care. Another concern is sometimes we might use the wrong word for certain things. There's some degree of normality in that, but if it's quite frequent, then that is also a concern. So, case in point, if you're not sure, hopefully you have a doctor you trust, and you can go to your doctor. And if that's not your primary care, you can seek out a specialist. And if you really want to dive deep on this and to see different types of specialists, there's all different types of doctors that can help you with this. Here at GW, we have a range of doctors that can help you, whether that's you go to your neurology team and see a neurologist. Maybe you go to our memory clinic here at GW and see Dr. Prather or Dr. Achalabi, and they're a geriatrician. Or you come see us in the Department of Psychiatry, and we can also hopefully help you out. So there's a number of professionals that you could see, starting with your general practitioner about this. And generally, if there is some concern, there'll be additional evaluation. And so we'll walk through what an evaluation may look like, but certainly just encouraging people to bring it up to their health professional. Of course, during the entire discussion that we have today, even though I have slides and it's a formal presentation, I do invite anyone to ask questions, and please type it into the chat. And if any of our other fellow discussionists will, if they have questions during my presentation, I definitely don't mind being interrupted. I'm happy to have some dialogue during the presentation. We'll continue on. When we're doing an exam for memory loss to help us decide, is this normal or not so normal? We really want to see how long has this been going on? When, is it getting worse? Is it getting better? What is the duration and course look like for us? How does it affect one's life? And generally, we will have some brief testing that will be involved with the exam as well. Hopefully, we're going to do some blood studies, because there's certain things that can affect your memory, from your hormones being off, or if you have some kind of nutritional deficiency. Especially for nutrition, your B vitamins are quite important for memory. And so we'll want to check sure and just make sure that we're not missing anything as we take our deeper dive into understanding the memory loss. If necessary, we may have even the patient go through a brain MRI. And this is, if you're not familiar with the brain MRI, this is a picture of an MRI machine, and you'd go inside that thing. It's nice and loud, so usually you get earplugs. And what will end up happening is they'll get a structural image of what your brain looks like. And it can help us understand if there's any structural reasons for why your memory is maybe not as strong as we want it to be. If we're still not certain, just from the deeper dive on exam, and we want to do much more testing, then that's where the neuropsychology comes in. And we do quite thorough testing. It usually takes a couple of hours, but the good news is hopefully we're friendly and it's not too unpleasant. And our exam does, like most other medical exams, start with actually a discussion. So talking about these symptoms and talking about how long they've been going on, and then putting you through a battery of tests, or the patient through a battery of tests, ranging from attention all the way down to memory, because there's a variety of things that can cause memory problems. An example of that is patients, adults, often here come in for exams for forgetfulness, and they have attention deficit disorder. Right? They're not focusing. So it's not necessarily a memory problem like we see in Alzheimer's disease, but actually it's a focusing issue that can be the issue. And certainly we don't want to stop with just your cognition, because there's a lot of things that can affect memory. I'm sure we're all can appreciate stress is very, very relevant, and how things are emotionally in one's life can certainly affect your memory formation, what you do, what you don't remember. So we want to make sure psychiatrically that everything looks okay. I'm going to run through an example and just a workup for a differential diagnosis that may be typical for us. And we have an individual coming into clinic here, and he's 68. He's having some memory problems, and he's forgetting some information. He maybe has missed some bill payments. He's withdrawn. He's sleeping a lot, and he's showing a little bit of a loss of interest in activities. Does anybody in the audience or any of our panelists have some ideas of what this patient may be experiencing? What could be a cause here?
How about his thyroid? He could be hypothyroid.
Yep, great. It totally could be thyroid cause. Yes, agree with that. Yeah, so thyroid is very relevant. Worst case here, I think we could even think Alzheimer's disease. This could even be a depression, right? So there's a range of things, and this is not, exhaustive in terms of the list that I have. But point being, there's a lot of things that can cause some memory loss. And 68, in terms of just base rates for Alzheimer's disease, before 65, it's quite uncommon. After we hit that threshold and into our 70s, the base rate, the prevalence of Alzheimer's disease starts to tick up. And so certainly that would be something we want to make sure that this individual is not experiencing. And to break down the type of memory difficulties that they may be experiencing, and we want to make sure that it's not completely abnormal, it might just be normal aging. When we're looking at their memory dysfunction in Alzheimer's disease, we're really focused on their ability to retain new information. In the early stages of Alzheimer's disease, it's the inability to retain new information, which is what's concerning to us. All of us, especially if you're busy or sleep deprived, has some degree of memory loss. There's a normal amount of memory of loss, but what's concerning in Alzheimer's and very characteristic of that illness is when an individual cannot retain, despite reminders, despite cues, even maybe taking their own notes. It doesn't tend to help. They tend to be disoriented. Right, so it's not, again, they're February 8th, near misses, but they tend to have bigger misses in terms of orientation. If they're a patient that may be coming from, let's say, PG County in Maryland, and they're in our office in downtown DC, they could tell us that they're still in PG County. Those types of things would make us more concerned for Alzheimer's disease. Speech is something that's a little less commonly understood in Alzheimer's disease, and what the medical term here that tends to happen in Alzheimer's disease, they'll make semantic paraphasias. So as an example of this, there's a tree here. A patient may call that a bush or a flower. It's kind of in that same ballpark, but it's not exactly the same thing, right? They tend to have very empty speech. So if you engage in small talk, they may be very good at kind of that cocktail party type engagement, small talk. They can say, different things to you, and you might ask them, for example, well, how are things going? Oh, good, doctor. Thanks for asking. And you could ask them about current events, and they may say something to you like, well, yeah, everything's really bad right now. And, regardless of your political leanings, I think there's a lot of truth to that statement. The however is when you start to ask for examples, tell me why, they have a hard time giving you the detail and the why. And so that is something that we'll look for is do they have that ability to give you that substance behind why they feel that certain way? If not, we become, again, concerned for Alzheimer's disease. Unfortunately, with Alzheimer's disease, the problem is not just limited to memory. We tend to see problems kind of across the board. And so that's why we test the other areas as well. And so we'll often see problems in problem solving or the reasoning abilities, or even in the visual abilities. So they tend to have more than just having memory problems, and that's why the comprehensive exam is important. Another feature of the diagnostic workup here in this example is this category called mild cognitive impairment. Has anybody heard this term before?
Yeah, I've definitely heard it.
Definitely heard it. Okay. And would the chat come up on the screen if people are writing in the chat?
Yes, it will.
Yes.
Okay, there it goes. Yes. Okay. This is a great question. What is the difference between Alzheimer's disease and dementia? Well, you're going to steal my thunder here a little bit because I'm going to get into that. But in essence, dementia is a clinical term and Alzheimer's is the cause. Okay, so dementia means you have cognitive decline, memory decline that interferes with your ability to care for yourself independently. There's a variety of things that can cause dementia. Alzheimer's disease is the single greatest factor for dementia in terms of cause. So yes, I totally agree. They're used interchangeably, but that is the distinction. Dementia is an umbrella term. Alzheimer's disease is one cause of that. Like in the U.S., we have, I think the estimate most recently is about 6 million Americans who have Alzheimer's disease. Dementia, there's more, but Alzheimer's is the single greatest cause. And I think we'll have a slide on this, but about 2/3 of all dementias are due to Alzheimer's disease. So mild cognitive impairment is just this in between. This is not normal aging. This is not dementia, right? It's an in-between category. The main distinction is they're still functional in the sense of their independence. They can get better. They can worsen. They can improve. This term was originally developed as trying to capture people who are in a pre-clinical stage of what may be due to memory loss from Alzheimer's disease, but in reality, it's non-specific. So people can certainly have, for example, memory loss from their thyroid, from hypothyroidism, and have some memory loss from that. And if we correct their thyroid, they can improve. So this is a category that is transitional. Some people will stay in this category, some people worsen, and some people improve. And it all depends on what the workup determines and what is the cause of the memory loss. So this is the very next slide. So I thank the audience member for asking that really important question, because in clinic, we really do see that confusion. And the academic distinction is that dementia is a severe cognitive decline that affects your functional independence, period. It's typically not reversible, okay? And there's a lot of different causes, Alzheimer's disease being the single greatest cause. But here are the different types of dementias. So on the far left of your screen, you have Alzheimer's disease, and you have frontotemporal dementia, you have Lewy body dementia, and you have vascular dementia. And so we'll review these. This is a nice graphic that shows you the different types of dementias. And the first three are progressive dementias, which means they're gonna, by definition, get worse. Vascular dementia is not inherently a progressive condition. We'll talk more about that. And Alzheimer's disease, frontotemporal dementia, and Lewy body all have neuropathologies. And so the neuropathology in Alzheimer's disease are right here, what are called amyloid plaques, and then there's tau tangles. And in frontotemporal dementia, there's tau as well, but also another abnormal protein that gets inside neurons, and that's called TDP-43. In the Lewy body dementias, you have, this one's easy because it's in the name of the dementia, these Lewy bodies that get inside the neurons and cause them to break down. That results in atrophy in the brain, which then causes the dementia. Okay, so these are the major different types of dementias, and we'll walk through them. And so this is a little bit repetitive because I just said this, but Alzheimer's disease is the single greatest cause of dementia. So about 2/3 of all dementias are due to Alzheimer's disease, and about 6 million Americans currently have Alzheimer's disease. It is due to amyloid plaques and then tau tangles. So the amyloid plaques are generally outside of the neurons, and then the tau tangles are within the neurons. And the result of the neuropathology here is they cause atrophy within the brain, and then that causes the memory loss. Another question we often get, and people want to know, am I mild? Is this moderate? Like what stage is my loved one in? Where am I at? So here are some just markers for you. And at the end of the presentation too, there'll be several links if you're more interested in finding, looking up information about these topics. There'll be some links to different sites you can have. But in mild Alzheimer's disease, it's generally people have difficulties with getting lost. They may have problems with some of their finances or medications. They may be repeating themselves, and maybe they're a little bit more irritable than usual. That would be pretty typical for mild Alzheimer's disease. Once we get into moderate, there tends to be greater problems with memory. They tend to have problems really learning new things. They may even develop some mild paranoia. So the symptoms certainly does unfortunately advance even with some of our new treatments, which is exciting. For example, the newest treatments are called monoclonal antibodies, and they're actually going after the amyloid plaques. So there are some exciting developments, but at present, there's no treatment that is reversing of Alzheimer's disease. So vascular dementia, what is vascular dementia? Vascular dementia is when someone has a stroke or there's some kind of damage to the blood flow. So a stroke can be either from, like this picture shows, a blockage where blood can't get through. And if blood can't get through in a long enough period, there's going to be cell death. And then that's going to result in some changes to your memory and, and actually other things as well, certainly your motor skills and sensory functions as well. The different types of strokes can be what is called an ischemic stroke. So that's a blockage. And a hemorrhage is when the blood vessel itself actually ruptures. Certainly, if you're presenting with any types of stroke symptoms, immediately go to the emergency room. There are different types of treatments in the ED that you could receive if you're in with close enough window. So it's not a wait and see type thing. It's an immediately go type thing. The course is generally going to vary depending on where the stroke and how many strokes. But by definition, vascular dementia is not like Alzheimer's disease, which that you have a progressive decline. It generally follows what we think of as stepwise pattern. So there's a drop off and then stabilization and even improvement if you do some rehabilitation. The next most common type of dementia in the US is Lewy body dementia. And you might have heard about Lewy body dementia because Robin Williams had Lewy body dementia. And we'll go through the symptoms here. And this is a little confusing, but Lewy body dementia used to be separated from Parkinson's. And now actually they're kind of together. And so Parkinson's disease dementia and dementia of Lewy bodies are actually together simply because this neuropathology, the Lewy body, kind of in the weeds name for in the science is called alpha-synuclein. That protein is the same protein that causes cell death in Parkinson's disease as it is in dementia of Lewy bodies. Okay. Point being, this is a really common and third most common dementia in the U.S. There's about 1 million people roughly. This tends to have a little bit earlier age of onset, usually in your 50s, versus like Alzheimer's is more like your 70s. The only big distinction between is it Parkinson's disease or is it dementia of Lewy bodies is actually the timing of the illness and the presentation. And so Parkinson's disease, you tend to not have memory loss or real significant type dementia symptoms until about 10 years into the illness. Versus dementia with Lewy bodies, you tend to have it at the same time in terms of the motor presentation. So you might present with motor in a sense of a tremor or some kind of gait instability, at the same time of having some degrees of problem with your cognition. And if you remember what Robin Williams went through, what are the symptoms of dementia of Lewy bodies? And unfortunately, there's multiple ones. They could be reflective of difficulties with your speed of processing, your focusing ability, your memory. There's all kinds of things that can happen, but generally you tend to slow down. So bradykinesia or bradyphrenia. You also tend to have some fluctuation in your attention. And there can be kind of confusion spells. And so patients and their family often their family may say, well, they just seem confused for like a couple minutes and then they'll snap out of it. That's a really common symptom that we see with dementia of Lewy body. Visual spatial difficulties can be alarming, and I'll walk through those. What's one of the interesting things we see is we'll see people's handwriting get smaller. We call that micrographia. And so we'll actually see this is just an example. Well, it's normal here, and then it gets a little bit smaller. Some people, and I remember my classmates when I was growing up, some people were just write really small. So you might know a person that done that. We're not looking for that chronic type of feature, but we're looking for the change. So if it's gone from a typical size to a smaller size, that is micrographia, and that would be certainly a concern, especially with all the other symptoms for something like dementia of Lewy body. The most concerning feature with dementia of Lewy body and alarming to individuals tend to be psychiatric. So they tend to have visual hallucinations. They tend to be well-formed. They also tend to be of small animals, like I have here a bunny. They tend to be a bunny. What's reassuring here is that the patient oftentimes is not alarmed by these things. The individual themselves who is experiencing it is actually generally not that distressed by it. The family often is very concerned that they're seeing things, and the concern is they're going crazy or they have some kind of schizophrenia or psychotic illness. But this is a very common feature of dementia of Lewy bodies, and is something that is usually well managed. It can be treated sometimes with medication, but it is an important distinction to know that it's common in this illness, and it's generally for the individual not that distressing. Generally, if you think about other types of psychosis, the things that they may be perceiving that others are not can be very distressing and very alarming, and they have a lot of degree of paranoia associated with them. This is not the case with dementia of Lewy bodies. Not to say that it's a pleasant thing, but it's often generally not an unpleasant feature for what they're experiencing. Different from Alzheimer's disease, they tend to benefit from memory, reminders, and cues, so they don't have that rapid forgetting that we see in Alzheimer's disease, but they do have some difficulties with memory formation and retrieval. The final type of dementia we'll talk about today is frontotemporal dementia. This is called FTD. And as our science get better and more people publicly talk about what they're experiencing, we're having more understanding and greater awareness. And so this is a broad category of dementia. It's less common, but it affects both behavior and speech. So if you've heard of a term called primary progressive aphasia, this is a type of frontotemporal dementia. And that can occur generally in your 50s. And if you're a movie buff, you might know that Bruce Willis, unfortunately, has announced that he's experiencing this. And if you follow him and his family on social media, they're showing their journey through this. And unfortunately, the speech is progressive. And so it's a true ability to generate words and communicate is what is affected in this type of frontotemporal dementia, which is specifically named primary progressive aphasia. The behavioral side of things, people can have a pretty significant personality change. They can develop apathy, or they can actually develop the opposite of that side of that, and they can be quite impulsive. So sometimes this can be tricky to manage. But compared to 15, 20 years ago, we have a much greater understanding of how this is developing and how to help the family and individual in dealing with this. So treatment, and then hopefully we'll get into prevention and what everyone can do on their own. And I think we should have plenty of time. Let's see what slide I'm on for discussion if people are interested in that. How do we treat dementia? Unfortunately, at this point in time, when we're talking about treatment, we're really thinking about management. We're not thinking about stopping an illness and reversing it. But this is something that is very, very important for us to try to help the individual and help the family. And it starts at diagnosis, right? It depends on what is the diagnosis. What is the prognosis based on that diagnosis? What are things that we can help with, right? And certainly there's medications, and I'm actually going to focus, being a psychologist, more on the behaviors and more things that people can do without getting a prescription from your doctor, right? These are things that you can do on your own. You can have your loved one do them. And so that's what I'm going to focus on. So there's two big categories here. There's physical health, and then there's mental health. Physical health is exactly kind of what it seems like. Make sure you're getting exercise. That is so important. Exercise. And, I think start where you're at. If you're not exercising, then maybe think about walking to the grocery store, or walking around the block, or walking up and down the stairs in your apartment building. Little things can be additive. And if you want a specific formula, it is going to be dependent on the individual, but generally around 2.5 hours per week can be a nice number. And it used to be that we were so focused on the cardiovascular system, and that certainly is super important, but there seems to be some degree of strength-based exercising. And that doesn't have to be, lifting very, very heavy weights, but little weights or resistant type training, decreasing the likelihood of experiencing frailty in late life can decrease your risk of developing any one of the dementias we talked about. And certainly if you're not sure, I think it's important to talk with your doctor for recommendations, right? And always use that as a resource. Managing those chronic health conditions, hypertension, cholesterol, diabetes, smoking, all the things that I think a lot of us know, but there's a lot of really interesting and important studies that are longitudinal in nature, and they have shown that even these conditions in midlife, 40s and 50s, can increase your likelihood of dementia in late life, several decades later. And so managing those, trying to lose some weight, eating healthier are certainly things that will be really, really relevant to brain health. Unfortunately, there's not always an immediate payoff, in terms of, okay, I'm going to change my diet. sometimes you don't see it right away. And sometimes that's hard to, the good stuff, the fried foods, the salty stuff, the red meats, all those things can be certainly really enjoyable to eat. But unfortunately, the long-term effects on our body and then subsequently on our brain is not great. And so more of the things you already know: vegetables, fruit, whole grains, fish, poultry, limit alcohol. And so if you want to say, I'm going to Google a brain health diet, I want one diet that's going to be brain healthy. Well, there's a combination that is taking the Mediterranean diet with the DASH diet, which is now together and cleverly called the MIND diet. That's an acronym. And if you wanted to follow something, that is something you could follow, and it can help you eat healthier for the idea of having a healthy brain. What are some things that I could do to keep my brain healthy from a mental health standpoint? How are you using your brain is the first question. Are you engaging in it? A lot of our patients have since retired, and they're finding ways to make sure they're staying active. They're taking courses. They're volunteering, right? They're staying active in their church. Those things are really, really great for your brain. And learning new hobbies, those, your brain is not a muscle, but you really can think about it as a muscle. You want to be using it and engaging and trying things out. That's going to be really, really important to keep your brain health. There's really less evidence for the stuff you may see advertised on TV or through your social media of what we call brain training apps. But it's a nice out of the box, if you want to go home on your computer at 5 p.m. and just do some brain training, it's not going to hurt. It's certainly not going to hurt. And it actually, certainly could help. But compared to the lifestyle stuff, getting into volunteering, getting into taking a course, those things are going to hold a lot more weight for your brain health and help you a lot more than doing these computer-based tasks. A few final things you can do. We find that older adults who are isolated really have an increased risk for dementia. So engaging with family who may have, unfortunately, some limitations in mobility or just transit, and they're isolated, they don't have people around them, having regular visits and with family and friends and maybe getting them connected with some social network can really help decrease the risk of developing a dementia. Stress is not good for the brain. So excessive stress is really not great. Try to exercise and journal and manage things and maybe do a little meditation. Everyone manages their own stress different ways. But the most important thing here about stress is too much stress is just not good for your brain. And so try to go from the half glass empty to half glass full, and that would be really, really helpful in terms of thinking and just maintaining your overall brain health. Finally, these are just some resources for everyone. If you want to take a screenshot or just go ahead and click on them or highlight them. These are just different resources. There's an NIA resource for walking you through, again, what is normal, what's not normal aging. Other resources within University of California, San Francisco, talking about healthy aging. And then finally, I put the link for the MIND diet for those who are really curious and trying to improve their diet on there. Certainly, I know it's easy to want a diet, it's hard to do it. And if you want to try to stay consistent, that's something that, and follow something specifically, that article and that link there will help you do that. I think we should have plenty of time for conversation and questions. So hopefully you had some questions you wanted to ask, and we can all have that conversation now. Finally, these are just links in case you're curious about GW and the things we have here. We have an Institute for Brain Health, which I'm a part of. If you wanted to click on my bio or the Memory Clinic, there are links up there for you. And Just wanted to give those as a resource. And if you're curious, the Institute for Brain Health is really it's Institute for Research, and we're really interested in trying to learn about the brain and engage with the community. There's a place to sign up if you're interested in being part of our research trials. We'd love to hear from you. And I know I've done enough talking, so I will open it up to questions now and look forward to hearing anybody's thoughts.
All right. Well, thank you so very much, Dr. Puente. This is a fantastic presentation. And I hope that many of our viewers will tell others to view. I encourage all that are viewing now to put your questions in the chat, and we are just looking forward to you asking questions. This was some powerful, good information, and you have the first one that's there. Do you have any thoughts on MCT and coconut oil as it relates to helping with Alzheimer's? So that's good.
Yeah. So coconut oil, I know there's been some discussion of that. Unfortunately, it really hasn't held up with future studies. I'm actually not familiar with what MCT is, so I don't know if can someone spell that out for me? But coconut oil is not something that is really been reliable. It's been like, I don't know if you heard about ginkgo biloba. That was another one that had a lot of traction initially, and it was a supplement, and it hasn't been replicated. So.
Yeah, I think it's medium chain fatty acids. I think.
Yes, the chain triglycerides.
Triglycerides.
Yeah, fatty acids.
Yeah.
Triglycerides.
Yeah. To be honest, I think that goes back to the diet thing, and I don't know if I would be able to speak specifically to that research looking at that exactly, but there's really clear evidence that even midlife obesity and midlife diet is linked to late life risk of dementia. We always kind of pair the things when they're closer together. How's your diet at 65 and 70? Well, that's important. But certainly is going all the way back to midlife. And so there's really strong evidence that, diet, especially fatty foods and so forth, at that age range will increase likelihood of dementia in late life.
Yeah. I'm very curious around methods of testing for dementia. And I'm just wondering about one, I'd like for you to speak about olfactory testing that's going on and how effective or not that particular methodology is. And then talk about what you do at GW, and very curiously, how many African Americans are involved in clinical trials?
Yeah, great. Really good questions. Well, the first one, olfactory testing, is really interesting, and so we actually have a smell test in the clinic, and anecdotally, what research has showed, let's say in Parkinson's disease, it actually might be the first symptom in Parkinson's. The problem is it's non-specific, meaning you can have loss of smell for a variety of reasons. Does that make sense? And so it can be sensitive, but non-specific. And actually in Alzheimer's, there's more evidence to suggest that actually it might be an antecedent even to the memory loss. So to your point, it's very important. I think we're still learning how to apply it in terms of when we get an abnormal result, this is important, this is meaningful. But does it, for example, differentiate between if I have a patient with a movement disorder or like Parkinson's disease or Alzheimer's disease? And it would not. But what's really fascinating is that it is so sensitive. And so it seems that we're getting some changes in the olfactory bulb, which is at the base of the brain, maybe at very early stages of the dementia, even before the cognitive changes are happening. So it's an active area of research I think is really interesting, and people are really interested in that. In the clinic, we do test. We'll have them smell like little markers and give them like four choices, and they'll have to guess. And we have pretty stinky ones, like a fish smell. And some people put it, they can't smell it at all. And
that's that sulfur type of smell.
Yeah. So it is really interesting, the question. Yeah.
I was wondering with regard to your testing, how many of those are Black, African American, like Latinx, or
Yeah.
it would be very good to know about those in clinical trials.
Well, if you've kept up with the monoclonal antibody treatments and the clinical trials that have just come out for Alzheimer's disease, which is really, last couple of years, it's kind of exploded. And these are basically going after the amyloid, which is the pathology in Alzheimer's. And it's been exciting in many ways because if you know Alzheimer's, we haven't had a quote treatment, right? We're still searching for this cure. It's not a cure and it's not necessarily a reversible treatment, but it's a treatment that is disease modifying. First time ever. So that's really exciting. That's the good news. Here's the bad news. Ethnic minorities, in particular African Americans and Latinos, were basically not there. And if you look at the cells and the participants in the clinical trials, there was a major limitation of the clinical trials. And there's 3 different agents, and I think they've gotten better, but generally that's been a consistent limitation and a really major one. So I know that people have brought this up and it's a concern, but that's kind of the state of the affairs for the monoclonal antibodies and the treatments for that. I would say, here at GW and Institute for Brain Health, that actually is an active area of engagement that we're interested in. And we're really trying to improve upon. We don't have any current clinical trials right now, but we do have other memory studies that we're doing. And we're trying to increase that representation because, even though it's a disease, it might look differently based, and you might respond differently to the medications and the treatments depending on who you are and what your background is. So that's what that's my opinion and thoughts on that question, which is really important.
Well, I do want to go to our co-host, but before we do, there's a question in the chat that says, basically, why is that? And they're referring to a lack of availability of participants.
Yeah. I think the why is a really complicated answer. I'll give you some thoughts that I have. I think this goes back decades. I think that medicine has a lot to do, especially from a brain perspective, to win over certain communities and trust of people. And there's a lot of reasons to have mistrust. That's one thought I have. I think there is an access issue as well. Plain and simple, are people advertising in where certain people are, right? Are the communities talking about these types of things? What about the Latino community? Is it in Spanish? Do you have, right? The most obvious things. And I think there's a lot of practical things that we can improve upon. But hopefully talks like this and discussions like this actually bring up this issue, which is a major thing. And we can increase awareness and get people motivated to help change this.
Yeah. I couldn't agree with you more. There's a lot of mistrust historically. That is really proven itself over time, but there's a lot of misinformation that is also out there as well. But I do know this: if we're going to advance the science, then we need to make sure that we pay very close attention to our participation, and I say our Black and Latino participation in clinical trials. And at some point, we have to do more trusting. What do you think, Dr. Melancon, Dr. Callender?
I wanted to ask Dr. Puente about the association of hearing loss and Alzheimer's and dementias.
Yeah, well, you guys are asking some really great thought simulating questions here. I think this is an interesting one because this is one where this is a low hanging fruit. My loved one or my father or my mother is not hearing well. hearing aids will reduce the likelihood of dementia, full stop. And then the next interesting part is the why. There seems to be more than just the hearing. It's more than just, if we give a memory test in clinic and you don't hear the words I read to you, well, your memory score is going to be bad, right? In terms of the risk of dementia, what I think people are trying to understand is that why, but it seems to go beyond. Your memory improves beyond what we'd expect just for having the hearing aid alone. So there's some kind of stimulation the brain is getting once you're getting that sense back or improved. That I don't have the perfect answer to, but it is very fascinating and actually well replicated.
I have a really non-controversial question. So in the presidential election in November, we're going to have two individuals, most probably, that are going to be septuagenarians, almost octogenarians. And, there's a lot in the public sphere about the deterioration in their mental health. We have one individual that, seems to be having more trouble remembering things. And then we have another individual that can't seem to ever tell the truth. So I'm just wondering, is this something that is that you think is just normal, or is there something abnormal going on here?
Yeah, and I like how you preface non-controversial question here because it is about as controversial as you get. I mean, I don't think it takes a trained professional to understand that the former president was not always in the best mental health, right? And that's just, I can say that. The second, which is I think interesting, is what can we expect for change? And to your point, Biden's is he 80 now or going to be 80? He'll be 80, I think, at the time of the election. And I think Trump will be, if he ends up being the candidate, 78. If you go on base rates alone, at 90 years old, 1 in 3 people, unfortunately, will have Alzheimer's disease, right? And so that's just the odds that you're looking at. And so at 80, right, you're kind of creeping in that direction. And, certainly it's a relevant conversation to have. And this actually goes back to Reagan, and Reagan had Alzheimer's disease. And one of the interesting things that I did in training is they had some studies that analyzed his speeches, and they showed in his speech patterns that he was showing signs of the illness before it was publicly announced, and this was during his presidency. So, I don't have the best answer beyond the fact that I think what you said, in terms of asking ourselves, is it a relevant thing, and what should we expect? It very much is relevant, and I mean, frankly, it's a little scary in many ways, but I think one candidate is a lot more mentally sound than the other. I'll put it that way.
Great answer. I have one
well
more question.
Stated.
So how about, on television, these commercials, we see these commercials for these supplements that are supposed to just fix your brain, fix all of this. Is it just total malarkey, or is there any value to any of that stuff?
Yeah, it's a really interesting question. I think, as you know, it's non-FDA, right? So there's no regulation. So that's actually an interesting point I wanted to talk about, because a lot of you dig down in their studies, they're really questionable at best. And so, for example, I'll name Prevagen, and Prevagen, if you look at their studies, it just doesn't seem to hold any kind of weight. And so what we find in the supplementation area is that if you actually have a healthy diet, that's going to carry way better effects for your brain than supplementation. The Prevagen is quite expensive too if you go buy it at your local drugstore. So my always advice is try to get the healthy diet. And then if you need to supplement, like your B12, like if you're vegan, your B12 might be hard to get, you can supplement. But then going beyond normal levels, at least right now, there's no evidence in kind of a typical population that going beyond normal is really going to improve with kind of what these supplements are trying to advertise.
Okay.
Well, I think whatever Dr. Callender is doing, we need to bottle that.
Yeah, that's for sure.
He's not showing any signs of his age.
Not
Well,
at all.
Well, if I am, nobody's picked it up. But at 87, I'm grateful that my mind is still working most of the time. But one of the questions I would like to ask him, Dr. Puente, is there any medication that actually helps any of these dementias?
Yeah, and so it will depend on the specific type of dementia. Broadly, acetylcholine esterase inhibitors, so donepezil, Aricept, is one that can be work for Alzheimer's disease, dementia of Lewy bodies. So that one you can kind of be a little bit looser, regardless of the diagnosis, the specific cause. But if we're thinking about Alzheimer's now, we're starting to get the monoclonal antibodies, which started with Aduhelm and so forth. And so the answer is yes, asterisk, there's no medication to date that will stop a dementia in its course.
Sure.
So, yeah.
Any follow-up, Dr. Callender?
No, because I was aware that they have so many products that they allege are beneficial, but when push comes to shove,
Yeah.
there doesn't seem to be any evidence that supports these allegations.
Yeah.
Yeah.
We go ahead,
Yeah,
Dr.
the other thing I was going to say is, and tell me if I'm wrong, but what I've seen in the studies where they've looked at older people, where you take a bunch of people like, Dr. Callender or people that live in a certain area, and it tends to be when looking at these outliers, why they do so well into the 80s and 90s.
Yep.
That's mostly diet, number one, and then this sense of community and support, right? I mean, is that true?
Totally true. I think that's what's so interesting as a psychologist. Like, you maintain your sense of purpose. What's important to you? What drives you? So exercise is important too. So we got to throw that one in there. But certainly psychologically, sense of purpose, community, your diet, super relevant for brain health. And maybe Dr. Callender can jump in on what they call the super ager studies. And they do a lot of those at actually University of Chicago and Northwestern, and heard a great presentation. And what that means is if you're in your 80s, you have the same memory capacity as someone in their 60s. And so you're basically 20 years in reverse in many ways, while keeping your crystallized intelligence above the 60-year-olds.
Wow.
Well, I think you mentioned some things, but meditation is something that I think that we have to put in the midst of all of those. Exercise, meditation, and as you mentioned, the dietary. Those are things that I think are helpful.
Yeah. Can I just say prayer?
Yeah,
absolutely. Yeah. Go ahead.
Can I just say prayer? Many things are overcome with prayer, and the strength of one's faith. The strength of one's faith. I'm not sure. Miss Brooks Williams made a comment that her mom, 75, was on Dawn, whatever that is. And I saw absolutely no change or improvement in her condition. I'm not sure what Dawn is.
Is it DON?
Yeah.
Maybe it's donepezil. That's the only thing I think that's Aricept. Unfortunately, that's not uncommon. There tends to be pretty minimal changes, and unfortunately, that happens.
Yeah. Well, I've been given the signal that our time has run out, but this has been a good one. And Dr. Puente, you're going to have to come back, and we're going to have to hash this up some more, because brain health, brain aging, normal and accelerated, I'll say it like that. We need you to help us figure that out. I'm just indeed grateful. Any quick closing statements, Dr. Melanson, Dr. Callender?
Yeah, and we'll save this for next time. But everybody in this city is smoking marijuana, so we want to hear about the effects, the long-term effects of marijuana on the brain. I know it can't be good.
That's a great episode. Great episode. And let's do not only brain, but let's argue creativity. And then let's look at synthetic versus, okay. We can talk about all of that because all of it is very real and it touches the audience in various places. Thank you so very much, Dr. Puente. This has been phenomenal. And I just want to let the audience know you need to tell your friends, your cousins, all your relatives to go watch Kidney Talks with the Ron and Joy Paul Kidney Center at George Washington University. I'm Reverend Kendrick Curry of the Pennsylvania Avenue Baptist Church, along with Dr. Clive Callender of MOTEP, which is the Minority Organ Tissue Transplant Education Program, and Dr. Joseph Keith Melanson, who is the Chief of Transplant Surgery at the George Washington University. And we're just excited to be here. You all take care. Have a fabulous time. Be well. And bye-bye for now.